Good afternoon, and welcome to our webinar, Redesigning the Pediatric Care Model in the Growing Surge of Value-Based Care. This is Dr. David Nace, Chief Medical Officer here at Innovaccer, and we are very pleased that you've all decided to join us for this webinar. I think you'll find it very interesting, and we're going to learn a lot about how pediatric care in this new world of value-based care is a very different perspective to how we think about moving forward. But first, before we get started, let me go over some housekeeping rules for all of you. We'll be taking questions periodically during the webinar, and what we're going to ask folks to do is in your chat box that you see, just enter into the place where there's a space any questions you have during the course of the webinar. I'll see those as moderator as they come through, and during key breaks, such as when we take a poll and we're waiting for poll results, I'll be posing those questions to our panelists. At the end of the webinar, we'll wrap up with any final questions, and then thank you all for coming to the webinar today. So with that, let me start by introducing you to our speakers. So I'm thrilled today to invite Luke Harris, Director of Operations and Population Health Management at Children's Mercy, Kansas City. Luke, welcome.
Thanks, David. It's great to be here. Thanks for having me.
Awesome. Great to have you. We also have joining us in the panel is Dr. William Bill Feaster, Chief Health Information Officer at Children's Hospital of Orange County, or what we have been increasingly calling CHOC, given its prestige. Bill, thanks for joining us.
Yeah, thank you, David, and hello to everybody out there. Good morning and good afternoon.
Awesome. So with that, let's move into this important question, I think, for all of us is, how's the current wave of value-based care impacting pediatric organizations? So we know that the world of children is very different than the world of adults. Let's start off with you, Bill. Maybe you can talk a little bit about how the habits and lifestyle of children are very different compared to adults.
Well, there's tons of things that are different in kids. They really aren't little adults as a lot of people might think about them. They have completely different lifestyles. They have different diseases, much less prevalence of chronic disease, as you can see on this escalator going down with the smokers and others. Very little of their conditions tend to be due to self-imposed diseases through smoking and alcoholism and drug use, etc. So they're kind of the innocents, and I guess that's what drew me to pediatric care to begin with. And you've got an entire lifetime ahead of them, whereas a lot of the care in adults, you're managing chronic diseases at the end of life. Here, you're kind of kicking off a life of a child and trying to make sure they enter that life as healthy as they can be.
No, that makes a lot of sense. So, absolutely, wellness is so important in pediatrics. Luke, maybe you can share a little bit about your perspective from Children's Mercy in regard to this concept of children's being different.
Yeah, I would completely echo Bill's comments. I guess the one different take that I would have is as you think about the approach to value-based care and the resources and the tactics or the technology, I would counter and just say that oftentimes those elements are very, very similar. What's very different is then how do you allocate those resources or those tactics on the conditions that particularly matter for children. And as Bill noted, there's much more focus on prevention and healthy lifestyle.
I think you've brought up an important point, as we see on this slide, is, children often receive care at different locations. They may go to daycare, they may go to schools, they may be seen in the community. You can speak a little bit about that as well.
Yeah, I think it's a great point, because obviously the equivalent of the work environment from an adult perspective is the schools, and that's something at our organization we're increasingly paying closer attention to of how do we develop a strategy to really further integrate our services within those schools. And I'd also mention kind of another really important point that I'm seeing here is just the impact of the parent or the social situation, right? You know, it's so I'm thinking about the home environment, and obviously a child is not in control of their home environment. So we're often, you know, have that situation where the parent and the home environment that they're creating is going to play a major role in the work and how do we optimize their care.
That's really insightful. I certainly remember when I did my first pediatric rotation in medical school about thinking about all the different stakeholders that are now interested in the care and that I have to coordinate with: the teacher, the parents, maybe they have somebody in the home helping out with their care, the grandmother, the pediatrician obviously plays that role in coordinating all of that. Dr. Feaster, I know this concept of handing off to adult children, to adult physicians, little Freudian slip there, handing off to adult physicians, you know, once children go off to college, and you know, that needs to be a really smooth process. Maybe you can speak a little bit about the importance and differences in the practice here.
Well, unfortunately, a lot of the time this is overlooked. They just figure that a child, they're old enough now, they go find an adult provider, and the continuity of care in that situation is poor. You need that handoff has to be carefully orchestrated, and I think it's particularly true with kids with various chronic conditions. But I think, you know, it's obvious for kids with congenital heart failure and cystic fibrosis, we do an okay job. But what about a kid with mild autism, or a child with learning disorders or ADHD on drug therapy who's going off to college and then needs to have continuity of care? So I think we need to focus a lot more on that.
No, that's really important. And that brings up this whole issue that, you know, children deserve a little extra care, a little extra focus, a little extra work in terms of coordinating things. Luke, it sounds like you were about ready to say something.
I was just going to say that I couldn't agree more, and I think it's something that is often overlooked, but there's some great resources out there. If you're not aware, there is a organization called gottransitions.org who's really trying to put evidence-based practices. We're fortunate here to have a team that's really dedicated on these transitions, and we're working collaboratively with them as how do we tie this in and evaluate the success of those transitions through a value-based construct. So try to put some data and information to just how important those transitions are to managing their care and outcomes.
You know, you bring up a really important point that's the heart of what we're here to talk about, which is the concept of value-based care, right? And as we all know that we've been trying to shift the world by changing the way we pay for care to support the new way of providing care in a value-based way. And we often talk about per member per month payments. For either of you, can you say a little bit about how this works in pediatrics? Has this been working, this concept of per member per month or value-based payment in the pediatric world? Bill, why don't we start with you?
Well, it's working, but the problem of having maybe a payment that's a tenth of what it is for an adult patient. I mean, part of the problem is kids are not a large percentage of the healthcare economy. They only consume about 10% of the healthcare economy. So it's sort of assumed that they're pretty much healthy and you're doing just sort of routine well child care. However, it can really vary drastically from child to child in terms of all the other things we've been talking about, in terms of how much chronic disease they might have, or how often they have to access various resources, or how bad their asthma is, and how many times they end up in the ED and other things. So it's not as straightforward as I think people assume.
Yeah, that's such an important point. You know, and then we have this whole, culture of wellness that we have to think about in terms of optimizing care. And we also have to look beyond this, right? So Luke, you've been successful at Children's Mercy thinking about how you can be successful despite these lower payments, these lower PM payments, this less attention on value-based care. you say a little bit about some of the key things that need to be thought about in terms of executing value-based care across the care continuum?
Yeah, I would say, I mean, we really do take a full care continuum position, and we're in a fortunate position that we've been able to make the per member per month model work in a capitated fashion in Medicaid. And I think the key considerations there is obviously having the knowledge and expertise in assuming risk, but then even probably more importantly, how are you going to operationalize and obviously then succeed? It's one thing to understand the risk that you're taking on, and that's one skill set, and then another from an operational perspective. And one thing I would comment on is you have to make sure you clearly understand the state of the Medicaid program and its ability to adequately fund the Medicaid services, because was one of the limiting factors where we have a capitated model in the state of Missouri, and we had not approached that same model in Kansas until recently because that situation changed.
So it's interesting, if you develop this broad kind of continuum and we think about the importance of really focusing on children, Bill.
Yes, sir.
I'm just curious, children are so different. You have this interact with, you're thinking about all of these other players in the ecosystem. You've got this lower payment. What's your perspective in trying to get the continuum to work together?
Well, I mean, a lot of the care that we provide is really focused on primary care. A very small percentage of pediatric care actually requires the hospital or a specialty service. So it really emphasizes the importance of pediatric care, well child care, immunizations, et cetera. And those chronic conditions that are increasing in frequency in the population, such as asthma, obesity, learning disorders, autism, et cetera, are primarily managed by the pediatrician. They don't need an endocrinologist or pulmonologist or gastroenterologist to do the vast majority of care. When that is required, it needs to be readily available, high quality, and cost effective. But we really have to, in pediatrics, focus primarily on improving the primary access to and the care provided in our primary care practices.
And one area we've focused on directly in alignment with that, Bill, is, and I know you'll agree with this, is how do we continue to elevate the acuity of our primary care providers, and or what level of acuity of conditions they can manage, but then also because our care continuum, like you said, is very primary care focused, it's then how well are we engaging the patients and families to take control of their care and partnering them with community agencies to help influence factors that are like the social determinants of health that are impacting that family.
Yeah, this is fascinating. I remember when we were founding the Patient Centered Medical Home movement in DC, the concept of the medical home, having all records regarding a children be coordinated from a pediatrician's office, really started in pediatrics. The medical home started there. So this is a great conversation. We've talked a lot about so far about this value-based payment and value-based care, Medicaid being a major force, but there seems to be an assumption that there's less opportunity for improvement, right? Bill, I think you mentioned there's less of the pie, so to speak, is the financial pie is on pediatrics. So what's been the result across the country? How have pediatric organizations varied in their thinking about value-based care? How variable are they? Are some people early, some people late? What's going on across the country here?
Well, we've been doing this for quite a while because we've had about 25 years of experience with a full capitated full risk contract with our county and Medicaid patients, and about 150,000 Medicaid patients, where we'll be talking about that a little later specific to CHOC. But so we have a lot of experience. So we recognized early the needs to develop the technologies and the services to manage that population. But that's most of pediatric care is not value-based yet. It's growing, certainly, and there are certainly good examples of different hospitals around the country that are beginning to focus on and do have increasing or large populations of capitated patients or patients in different value-based arrangements. So it's definitely increasing, but it's probably not there to the level it is in the Medicare populations. So we're probably a little behind, but I agree with the slide where it says Medicaid is the driving force. That's certainly the driving force for us. It sounds like, Luke, it's also the driving force for you of getting into this business, and partly because the margins are so low in that business.
Yeah, I would agree. Just a couple of additional comments there is, it's one thing that we learned. I mean, we have the health plan experience from 1996 to 2011, and that helped kind of lay the foundation. But one thing that we learned, we really only started to approach commercial payers relatively recently, and the comment there is because with commercial payers, it's going to make up such a small proportion of their book of business. You really have to go in with the mindset of we're going to utilize the framework that payer currently operates for their value-based agreements with adults, and now how can we use that framework and now tailor it specifically to pediatrics. And we've been fortunately successful to be able to do that with 3 of the 4 major commercial payers in our market.
And that's fascinating. It's often hard unless you get all the payers aligned to really both innovate, but also to be able to deliver an integrated approach, right? Because you really need to have kind of all ships going in the same direction. Can you, let's start with you, Bill. Let's talk a little bit about this concept of an integrated care and the importance of that in value-based care.
Well, I mean, it's pretty obvious that if you are going to, whether it's adult patients, pediatric patients, or anyone, the more data, the more, it's not really control, but the more knowledge, the broader you can spread your technology, the better you can manage across a care continuum, the more likely you're going to be successful. Like one of the things that we've really focused on is bringing primary care practices into our organization in a relationship such that we can bring them onto our EMR, we can share data back and forth, we can apply some of our population tools, and as we're going to be approaching getting about 40% of all the patients in Orange County on the same system with sharing data using the same tools. As we start doing that level of integration, we can start making some real impacts on care, not just on the capitated patients, but also on the care provided to all patients across the region. So I think that's sort of our focus for integration, is not just the capitated Medicaid patients, it's the entire population.
That's exactly that's exactly what we saw, Bill, and we've seen this when we formed our clinically integrated network approximately 4 years ago. I was pleasantly surprised by when we started and formed that organization with really the mindset of having full transparency, because we couldn't really operate and improve and learn from each other. And when I say each other, I'm talking about each of the independent community-based practices that are coming to drive improvement in pediatric care. That really wasn't possible without full transparency. And then the amount of movement that we've been able to achieve, and this was before we even had incentives in place relative to value-based agreements, was really incredible. And I think it has to do with, I like to call it the social competitive forces, which docs are naturally competitive. And when they start seeing each other and you share that effectively, it really drives change.
Well, this is a fascinating discussion, gentlemen. Let's go ahead and turn to our audience and take a quick poll and see where they're at with their journey into value-based care. So we're going to pull the poll up. What phase is your pediatric organization currently in regard to the implementation of value-based care? Are you feeling like you're not really doing anything yet? Are you just a beginner? Do you kind of feel like you're starting to understand value-based care and you've implemented a few things, or are you an expert? Have you implemented and practicing a robust technology-based, value-based approach today? So while the audience is submitting their poll results, there's a couple questions from the audience. Start off with this one for you. What is the effect of behavioral health issues on development? Bill, let's start with you since you brought up behavioral health earlier.
Wow. It depends on, age from 0 up through 18, if you want to take that as kind of, throughout the entire spectrum, how from early stimulation through, how children adapt to their environment as they age. Just the influence of school is incredible. I don't know even how to begin to answer that one beyond, there's a lot of behavioral health issues that we tend to ignore as children age, and particularly the whole issue of depression and ultimate that we have way too many kids that are committing suicide, which is the ultimate effect on aging. So we have taken a focus here on behavioral health, and we formed a inpatient unit, outpatient programs, and are doing our best to supply services to the kids who are in need. But I think the example was given that of all the kids with behavioral health problems in Orange County that need to be addressed would fill our Angels baseball stadium, which holds 48,000 people, which is kind of scary if you sort of think of it in that scale and what limited resources even focusing on it we can provide.
Got it. That makes sense. Our poll results are coming in, but Luke, this behavioral thing, I remember when I was treating children, like the behavioral aspects for the adults often influence this kind of the game and how I would approach care for the child. What's been your experience at Mercy in regard to behavioral issues?
Yeah, this is an area of increased focus for us, really within the last couple of years and going forward. We just started taking on risk within one of our capital arrangements for the behavioral health component, which we hadn't in the past, given the importance and the impact that it has on their overall medical cost. I know on the adult side, they often say, somebody that has a comorbid condition of a behavioral health condition is 3 to 4 times more costly, and I'm sure that would also hold for kids. So our focus historically, or within the last couple of years, has been on developing some training of how to elevate the behavioral health competencies of our primary care practices, and we've done that in partnership with some of our specialists. We're now trying to take that a step forward, and we're trying to further integrate those capabilities and make sure that they're reaching the clinical flow and the clinical operations of our primary care practices.
There's one other kind of interesting fact. In our area, the county pays for behavioral health services for all the Medicaid or Medi-Cal patients. Private insured patients, none of the private providers in the community take insurance, so they're cash only, and some of them have no access to behavioral care services or mental health services. So in fact, the Medi-Cal patients, the Medicaid patients, are the only ones that have paid access, which really is astounding to me.
Fascinating. Well, let's go and see what our poll results are and check on our audience to see where they're at in their journey. We can pull the poll results up. Here they are. Wow, this is very interesting. Very interesting. Gentlemen, what do you make of this? Start with you, Luke.
I think this is in line with what I anticipated or expected. one thing that as I reflected on this question in advance of the poll is I'm curious to see how many are if this same question was asked, but in light of pediatric value-based care. We're asking it generally, and I know that we don't have the capability to kind of re-poll to ask that question, but that's what I think about, and this is in line with what I would have anticipated.
And Bill?
Yeah, I would probably say the same thing. Might have expected a few more people to be expert, but I'm at least encouraged by the fact that 46% have implemented some aspects and understand it. So I think that's probably, if we had polled 4 years ago, when we were just starting out, or 5 years ago when we were starting out in this area, I would imagine that number would have been a lot lower.
Well, we're very fortunate to have both of you as experts on this panel, so that the rest of us can learn from. So this is fabulous. So speaking of that kind of expertise, let's turn to Luke and talk about the history, the current story of Children's Mercy Kansas City, kind of where you're at today. Tell us a little bit about the organization and specifically around pediatric care and pediatric value-based care.
Yeah, so this is just a quick overview of the stats of Children's Mercy Kansas City. We are the only pediatric trauma center between St. Louis and Denver. I'm not going to run through those other stats, but what I would highlight here, we are a mix of both employed and non-employed physicians. We are most of the specialty services in the Kansas City metropolitan area, and really kind of the piece that I want to highlight and mention a little bit of the history on is really the lower right-hand corner, which is our pediatric ACO entity. And really the foundation of that entity is in the history of our Medicaid health plan, which we had from 1996 through 2011. We sold that health plan really because of the threat of expansion of Medicaid into adults, and just because adults were not our core business. But we were fortunate because we kept a lot of the key infrastructure that you would need to be successful in population health and accountable care. And so we were actually able to continue to retain delegated functions from the managed care organizations for disease management, case management, and utilization review, and keep some key infrastructure to support that. And that's how we're able to still have approximately 125,000 fully capitated Medicaid members that we're responsible for. And as I had mentioned, within the last few years, we've been able to set up a clinically integrated network and really advance in parallel a value-based strategy on the commercial side. These arrangements are all upside only at this point, but because of national pressures and just really the movement towards value-based and the need to start to assume some element of downside risk, we're in some discussions there as to what does the future look like for those value-based commercial agreements.
So preserving those functions seems to have served you very well in this endeavor. Hey, you can share a little bit about your results to date.
Yeah, so here again, you can just see the 7 value-based payer agreements that we have in place. One stat that I think is what I'd like to say is a crossing of the tipping point, if you want to call it that. And I know that's a question that often comes up on the ability to invest in this and really kind of move forward. But we estimate that of the kids in the metro area, 34% of them, of all kids, are in a value-based agreement with us. And then you can see just the makeup there in terms of PCPs and the number of lives, as we mentioned. On the right, we're just highlighting some of the successes that we've had. And these percentage point increases, to the point that was made earlier, these actually aren't just within our value-based agreements. This is for all patients receiving care at the practices that are in our network. And so you can see just really substantial improvement. And a lot of it was there wasn't actually maybe as much awareness or understanding from the individual practices. And then, like I said, the competitive forces that then helped drive their improvement. And then how do we support their improvement, which we'll talk about momentarily. But that really led to the successes that you're seeing in these bar graphs.
Now, that makes a lot of sense. And, Bill, I think you can't really be successful in this world and get these kind of results without really data-driven strategies. I love this little cartoon. The results of your test show you're not allergic to vegetables. It really is about the data and what the data shows. So, Bill, maybe you could share a little bit about the importance of data that you've seen in executing in this way.
Yeah, I love the cartoon too. In fact, I love that early cartoon with the escalator. I thought that was particularly good. I think I will use that. I'll scavenge that and use it for a presentation. It's really cute. So the data, having reliable, repeatable, curated data to present to people taking care of patients, I think is absolutely essential. If you don't know what your, if you don't know that you're not conforming to guidelines, if you don't know you're not doing something that's very important, like Luke was saying, HPV or whatever, sometimes they slip through the cracks, it's a good thing to do. But reporting back to providers how their individual performances for their practice, and Luke kind of mentioned it early, particularly when there's transparency around that, leads to incredible improvement in performance. The other thing is you have to engage providers in developing metrics that they're going to be held accountable to. It can't be sort of it's not a message coming from God that they need to do something. They have to be part of the process. They have to be helping participate in defining what best practice is, in holding themselves accountable to metrics that others are holding themselves accountable to. So it's not just we provide data to someone and we have to have them participating in everything that we do, and it has to be accurate. Or presenting data to a physician that is inaccurate will immediately discredit all your efforts.
No, that makes a lot of sense. And Luke, certainly in our discussions between Innovaccer and Children's Mercy Kansas City, we've talked a lot about the importance of having trustable data, building trust in the data, having that data transparent and having it available as insights with, common understanding of what they're working with. Say a little bit more about the concept of having open, transparent, and reliable data from your perspective in this regard. What's been your experience?
Yeah, no, thanks. And it would just kind of build upon Bill's comments there about engaging providers, and it really then ties into this building trust. And when I say providers, I'm really referring to the full care team of the practices and organizations that we're working with. But the building of trust for us really gets down to a pretty detailed level. And just to kind of take it down to kind of a more practical example, as we put in place the solutions that support our population health capabilities, we really take the time to gain that trust. And we'd often, we would allocate a 2-month period of time. And what we would do is we would take the first month and we would sit down with the practice and a few of the key team members, and we'd say, really scrutinize the data and tell us everywhere where the data is wrong. And then we work with them to either explain any issue with the data, or we get it fixed so that now we have trust and now we can move forward to drive improvement.
Yep, engaging physicians is so important here and making sure that they're trusting the data and using it. I think that's so critical. We're really talking about the use of population health technology in addition to having solid data. Bill, you certainly, looked a lot at us around Innovaccer. What did you find interesting around the way we were approaching things compared to your needs for population health and this need for trustable data?
Well, we started, just as Innovaccer was starting out, we were adopting population health technology from our EMR vendor. And that's been a very successful relationship over the years. And we've developed a sort of a very sophisticated and advanced population health tool. We're looking at working with Innovaccer also to help interface between that data and practitioners and pushing data out and getting data back into our platform. So everybody, everybody may have a little different focus of how you look at a specific vendor. But I think what on this particular slide, what was very important is to, when the whole idea of when we push out technology, we're trying to make sure that people conform or aware of and conform to best practices. We're trying to not create cookbook medicine, but to look for standardization of care. There are certain things that professional societies have published that people agree with. This is best practice. And how can we help people provide best practice to their patients? Sometimes that takes the primary care docs working with the specialists to determine what best practice really is for a disease like asthma. And then developing tools on top of a population health database that is embedded in their workflows such that they can easily leverage those tools to improve care. And when I talk about asthma a little later, I'm going to use some specific examples of how those tools have led to that care improvement.
No, that makes good sense. And, these tools really need to support better communication between the members of the team, because we've talked about how important the teamwork is in kind of primary care for pediatric care. Luke, can you say a little bit of your perspective of the concept of better communication standards and protocols and the use of good, trustable data?
Yeah, and what I would say here is really the communication is critical to the success of the operations of a clinically integrated network. And what I mean by that is you really have to make sure that as you start to present this information and you see where the performance is of each practice, we really concentrate not only on being able to share that content with the physician leaders of those practices, but then how do we support each practice to be able to take that information and bring it down to every PCP in that practice, in the collective care teams, so that then they can embrace the information and then collaborate and work with us to drive improvement. And when we do drive improvement, we've really tried to develop tactics and strategies where we can help them. We look at it as a value proposition of our network to put ourselves in the perspective of that individual practice and help them prioritize, or at least, and I completely agree with Bill, we're not telling them what to do. We're trying to give them tools and resources to help guide them. It's ultimately up to that practice, but then we're always aligning it with the clinical standards that exist.
Yeah, I mean, one of the things kind of interesting, I mean, how many people that you talk to will ever say, gee, I really want to do a bad job. I really want to do a poor job taking care of patients, so any tools we can give them to make it easier for them to do a good job is really what we're talking about here, not trying to enforce, sort of a specific way, or not trying to punish for poor performance, but how can we give them tools that make them the best provider they can be?
Exactly. David, I think you're on mute.
Oh, I was saying, and also in driving value across the care continuum, right? That's the importance of pulling together these teams and having the technology to support them. Can you say a little bit about the value that's created by using these technologies? Luke, let's start with you.
I mean, we've had tremendous value in multiple mechanisms, and it's hard for me to try to articulate it exactly without trying, maybe asking for some of our practices. But if I put them in their shoes, I mean, they're very appreciative of helping to make sense and then of all of the information, and not having to, take and try to understand what different payers are approaching them with, and then also just being able to, no single practice could really invest in the technology or the infrastructure. It's not even really the technology, the operational expertise. So when I say that, we are an organization that is completely provider-led. So and we're guided by how they are directing us, but it's how do we bring the right information and perspectives or options, and then let them help guide where we're going.
No, that makes good sense. Let's check in with our audience again and ask them this question for our second poll, which is, how does their pediatric organization have a population health technology approach? Do they have a technology platform that can really support this continuum of care, this value creation? Do they not? Are they thinking about bringing it in? Let's go ahead and start that poll. And we have had so many questions come in from the audience. So a lot of people like the answer in behavioral health. Let me ask you another one.
Oh yeah, actually, I see a good question that I wouldn't mind taking if you don't mind. So the question is around, have we considered the bundled payment concept for chronic conditions? And so
Great question.
I'm pretty passionate about this particular topic. And what I would say is no from a payment mechanism. And I say that in terms of, we're given the size and the scope of pediatrics relative to the payer book of business, we're not interested in contracting for bundled payments, or I like to use the term episodes of care. But what we are doing is we're taking that approach and we're using that as an analytical framework and model by which we engage our specialists in a meaningful way to bring them meaningful cost and utilization information that we can partner with them to help redesign their care model and help inform the work they're doing. And if you think about capitation is just one really big bundle. So what we're trying to do is apply this analytical framework both within our capitated agreements as well as our non-capitated agreements, and now bring those meaningful insights to our specialists.
Yeah, maybe I'll tag on to Luke sort of choosing something to talk about, David, so we'll kind of preempt you asking me. But in addition to that, there was a question about risk adjustment for PMPM payments. We have an interesting situation in that California Children's Services, which managed, actually paid for on a fee-for-service basis, of the kids with significant expense chronic diseases like cystic fibrosis and type 1 diabetes, et cetera. We have now become fully capitated for those patients, which is the ultimate value-based contracting. It's a different rate of capitation that's much, much higher than the general pediatric population. So we've had to go into a carve-out type of arrangement for those patients, and now we're at full risk for hospital and pediatric and physician in all care, except for a couple of carve-outs on those patients as well. So that's a challenge. We have taken that on, not necessarily because we wanted it, because the state decided we were having that obligation.
Lots of good feedback on different contracting mechanism and the movement toward full risk. So these are great comments. I see the poll results are in. Let's go ahead and pull them up. And we have some poll results that show how many people have a technology population health platform. Gosh, can you guys see the results?
Yep.
Great. What do you think?
Well, I find it interesting that 53% of the patients have a platform, but only 4%, I believe, said they were experts at it. So we're probably in the phase of a lot of early adoption here, where people haven't quite figured out all of the various ways they can apply their technologies to improve care.
Great. Luke?
Yeah, I would just agree with those. I don't have any further comments.
Great, that makes sense. Well, it's interesting to see where people are at and trying to understand where they're at in this journey. Let's let's go ahead and move ahead. And we've already talked about data-driven strategies, decision-making, the importance of the quadruple aim, and the importance of learning from innovation, other innovators and learning from each other's organizations. Let's move on to talk about CHOC. Bill, you want to give a little bit of an overview from your perspective at Children's Hospital of Orange County? Like, tell us all about how you came about to this venture into value-based care and where you're at today.
Yeah, well, CHOC's fairly similar to Children's Mercy. I was kind of remarking about how some of the statistics are pretty similar in terms of numbers of beds and numbers of patients and visits and et cetera. We have also been in the business for managing at-risk capitated patients now for almost 25 years, and currently have 150,000 Medicaid capitated patients with full cap. And also probably, and I didn't put it down here, there's about another 50,000 patients that the physicians who are affiliated with us have in capitated type of an arrangements on the physician side. California is a little different in that we can't employ physicians in California. It's one of the prohibition of the corporate practice of medicine states. There's about 6 of them. So we create a foundation model, and the practices are actually run by that foundation, medical foundation. We have about 350 docs, 250 specialists, and about 100 primary care docs that are in that foundation, but also have a CHOC physician, CPN, CHOC physician network that has about 1,300 total providers in the region that provide care for that capitated population. To manage that population, we formed an IPA, Independent Practice Association, which is owned by the docs and the hospital. And that has all the underlying services that Luke was discussing in terms of becoming a payer and managing claims and case management and all the other things that are required to serve that type of population. Maybe go
well,
to
you've both gotten significant size, and you've both developed this sort of integrated networks. And it's pretty fascinating how Medicaid drives both of you, which is not unexpected given our comments.
Well,
so
given that
you were talking about
our patient base is like 60+% Medicaid. So it would be kind of logical that would, pediatric kids tend to be poor. So there's a very high incidence of Medicaid in that population.
So you made some decisions along the way here.
Yeah, in 2014, we had just finished opening a new hospital and was able to turn our attention to providing more services to our capitated population. Also around the same time, we were fired by our management company because they didn't like the sort of the low profitability of this population. So we were forced to manage these patients on our own and partnered with Rady's Children's San Diego to do so. But we also decided we needed better tools than just claims-based HEDIS reporting. So now we have a population health data warehouse that gets data from multiple sources, not only the EMRs, ours and others, but pharmacy and labs and claims, et cetera, both 837 claims as well as adjudicated claims out of our IPA. And all those claims are kind of ingested, cleansed maps to standardized nomenclature, uniquely identified and stored in population records. And that's kind of our basic platform. And then on top of that, we run programs for various things, whether it's for care management or analytics or whatever. But in particular, we developed condition-specific registries that are basically programs that run on top of that database that then are integrated back into the EMR environment and visible at the point of care. And we use that data to track, not only to improve care, but also to track our outcomes.
Luke, I would imagine that you have similar data sources and issues. Share a little bit about that.
Yeah, that's exactly right. I mean, we've often taken a historical approach that much of what you can do and be successful in value-based care can start with claims data. So, and really this was part of a cost and benefit analysis of just how much was it going to cost to establish comprehensive EMR data feeds with all of our independent community-based practices. And so much of our historical focus has been on establishing pre-adjudicated claims data from both all of our practices, as well as then obviously all of the true financial data from payers. But now, really, we're at a turning point, or have seen a turning point, and this is part of our partnership with Innovaccer, is that we've seen that come down, and we do feel that we're in a position to, advance beyond simply basing our data infrastructure on claims to really implement robust EMR data feeds to complement and really take some of the work that we're doing to the next level.
That's great. And, Bill, this is the dramatic moment we've been waiting for. You've had some great successes around certain disease states, and you wanted to share with us some of the great workings that you've done in terms of asthma. So tell us that story.
Well, asthma is just one of the things we focused on because it's so prevalent in our population, and it's primarily managed by primary care physicians. And so we've really focused on rolling out to primary care physicians into their practices, into their care, into their workflow, data on the patient in front of them, and also allowing practices kind of convene ahead of time, do huddles to determine what does a child need who's coming in that day. And, the reason we're focusing on is it's the most prevalent disease in our capitated population. It's the most prevalent disease in Orange County. It's about 13% of the kids have some diagnosis of asthma. We have lots of ED visits as our number one reason for ED visits. That's also one of the number one reasons for kids missing school. And so we really decided, well, let's start with this. Let's really focus on this. So we developed a registry for the care of asthma based on guidelines, and this really requires EMR data. It's the claims data won't be enough for this type of focus because, for example, one of our measures that we follow is, do you have an asthma action plan? And that's documented in an EMR, not in the claims data usually. And we've increased compliance with that over 300% in the past 3 years with many of our practices. And it was kind of interesting when we first presented them their data saying, well, you have, they thought initially all of their kids had asthma action plans. Turns out it was 16% for several of our practices, down about the low teen level. And they're now over 50%. And it's interesting that at the same time they were improving this, we were dramatically decreasing our ED visits. So we have just one practice that manages 26,000 of our capitated population, a large practice with 26 providers. And they saw a 19% decrease in asthma-related ED visits just year over year, just in the last year of time, and also similar decreases the year or two before that. So if you just use the fact that it costs our IPA a certain amount for taking care of an asthmatic patient, we've probably saved just on that alone $182,000 just in 1 year over ED costs. The other thing that's kind of fascinating is that people don't realize that EDs are generally overcrowded. Ours has 100,000 visits. We are built for 60,000. If you actually get patients out of the ED, you don't lose money. You make money because it has room for the kids that need to be there. So just being able to decompress your facility by getting unnecessary visits out of it actually is a financially successful strategy.
Luke, does that resonate with your experience with specific disease states and coordination with the rest of the healthcare system? All right, so we may have lost Luke, or you may be on mute. But
I think he's on mute here.
Oh, yeah, sorry about that. It does. Completely aligns, and just a little nuances here and there is just kind of the approach that we ended up taking. it's interesting to hear your story. And when I think about our story, it started more kind of focused on the asthma HEDIS measure, just because that's where the incentives were. And then it really expanded to be the approach that I'm hearing Bill take, which it's just such an important chronic condition for us, and it's really involved into a lot of partnership with our specialists, and University of Missouri was involved in, and then moving forward with providing those resources to support our practices.
Yeah.
Yep, that makes a lot of sense. Well, these have been some great insights that we've had, and we want to just move on to some questions that we have from our audience. We've already addressed a few, but we can ask a few more. Bill, it sounds like you're about ready to say something.
No, I'm just
okay. So
getting prepared for that question.
We talked. Well, you don't know which question I'm going to ask you.
That's right.
We've talked a lot about fee-for-service. We've talked about value-based care and payment mechanisms and capitation. I have a question for both of you. What do you think, and Luke, you've had a lot of experience with different different payment arrangements with different commercial providers. What do you feel the ideal compensation model is that really helps to incentivize everyone doing the right thing? Luke, let's start with you.
Yeah, this is an interesting question. And is the question on how the payer contract is set up, or is the question on the compensation model? Because those are two very different things.
Great point. Let's break it down. Let's talk about both. Let's start with the first part.
Yeah, I guess because this is such a complicated and wide-ranging question, my brief answer would be, yeah, I don't think that there's one kind of model that fixes everything, and it really needs to be a tailored strategy on this movement, because you can't just flip a switch and be there. So it is the continuum, and there's a tremendous amount of work out there as to what that continuum looks like, and you have to be pragmatic and strategic as to how that movement happens. On the provider compensation side, having many of our specialists employed, we're not asking our specialists obviously to take risk, but it's then how do we design that into their compensation model? And we're just at the forefront of that, and more to come. And then also, we're just at the forefront of how do we really work with our primary care practices and put in some element of risk. And to be honest, a lot of what we're learning there is looking at the approaches that are happening nationally in the adult space.
Great, and you have to align that with your payment mechanisms as well. So, Bill, your perspective?
Well, I think you have to, like Luke was saying, how you approach primary care might be different than how you approach specialty care. Incentives may be quite different. With our primary care providers who take care of capitated Medicaid patients, they're on a capitated payment basis also, with incentive compensation based on performance on HEDIS measures and other things. So they get a bonus. If we have money left over at the end of the year, they get bonused out, and they actually do pretty well on Medicaid, taking care of Medicaid. Some of them, half of their practices are capitated patients, so it's what keeps their practice going. For the specialists, we tend to focus more on RVU-based compensation within the specialty groups within our foundation, with incentive payments, with certain amount withheld for quality payments. So that tends to be a little different. And it's not true fee for service. It's more, the more you do, the more you get paid. But it's also tracked and monitored pretty closely within the group. The old RVU-based or the old fee-for-service-based models, then the problems that have been elucidated over the years for overutilization of expensive procedures and stuff for cardiology or other specialties really doesn't hold as much for pediatrics. So we don't have that risk in our compensation, fee-for-service compensation systems like the adult environment has.
Great. Well, that's the end of our time for questions. I think we've provided some great insights for the audience. I want to big thank you to both of you, to Luke Harris, Dr. Bill Feaster. You did a great job, provided some great illustrations of results that you've had and some lessons along the way, the use of technology, open, transparent data, and particularly really implementing this for pediatric care and bettering the health of kids and families in your neighborhood. So kudos to both of you for the work well done, and a big thank you for joining us. And for the audience, if you wish to reach us, team@innovaccer.com. Thank you all for joining us, and we look forward to being in touch with you in the future, and also for upcoming webinars that you'll hear from us. Bill, Luke, thank you very much.
And thank you, David, for doing a wonderful job moderating.
Yes, thank you.